Good evening, everyone. Welcome to the educational webinar on osteoarthritis and managing joint pain. We hope that you all are staying safe and healthy. And also we hope that you have received both the COVID vaccination and the flu vaccination. I'm Dr. Neeta Dhananjaya, Chair of the Health Awareness Committee of Indian American Medical Association of Illinois. And along with me, I have the co-chair, Dr. Sudha Bopalam. We'll be the hosts for today's webinar, and Health Awareness Committee, as part of the Indian American Medical Association of Illinois, works towards bringing educational programs on important health issues. And our topic today is osteoarthritis, managing joint pain. And we are very grateful to the Schaumburg Township Public Library for working with us in bringing this educational webinar to the patrons of the library and to our other audience. We have Dr. Sana Ghafoor Hasib, who will be discussing some of the symptoms associated with osteoarthritis, along with diagnostic tests and the treatment options you may consider exploring with your own primary care physician. I would like to introduce Dr. Sana Ghafoor Hasib. She's a practicing rheumatologist for the past 8 years, and she has completed her medical school at Des Moines University, followed by internal medicine training at the Medical College of Wisconsin, followed by her rheumatology fellowship at the University of Utah in Salt Lake City, Utah. And she served as the faculty in University of Utah for 4 years until her move to Loyola University here in Chicago in the fall of 2019. And she's also joined the rheumatology division at the Edward Hines Jr. VA, and her clinical interests include general rheumatology, Sjogren's syndrome, and she loves to teach medical students, residents, and fellows. Welcome, Dr. Sana Ghafoor Hasib. Thank you for being here today on your busy schedule, to bring us this educational program. And I would like to remind our audience, after the talk, there'll be a brief Q&A session, and you can type in your questions in the chat box or in the Q&A link in the bottom of the screen. And welcome, Dr. Sana Ghafoor Hasib.
Dr. Dhananjaya, thank you so much for such a kind introduction. It's really an honor to be here, and I'll just get started.
Sure, thank you.
All right, so my talk today is going to be about osteoarthritis. It's a pretty common disease process we see in the rheumatology clinic. I think usually it's the primary care physicians that hear about or make the diagnosis at first, and then generally patients can get referred over to orthopedic surgery, sports medicine, rheumatology, physical medicine, and rehabilitation. So a lot of subspecialists. So I think there's a lot to learn. I tried to keep the topic a bit general, but definitely keep your questions in mind, and we'll try to address all of them at the end. All right, so a quick outline about the talk. So I'm going to start out with some background information, go into some facts about what exactly osteoarthritis is, what risk factors, are there any that are even modifiable? One of the biggest questions people ask, is there anything I can do to prevent this from happening to me or to stop it or slow it down? What are some of the signs and symptoms? How do we diagnose osteoarthritis? And then delving right into the treatments. And treatments, if we think about it in two ways, what are some of the non-pharmacological, so non-medication ways? What are some of the pharmacological ways? What are some complementary approaches? So can two things be done at the same time? And then finally, when and if will surgery be a question? And what questions should you ask your doctor? So what's in a joint? What exactly takes place at that time? So the joint is an articulation or the meeting of two bones in the skeletal system. So this is just a very simple diagram of the knee joint of the two coming together. So osteoarthritis is when you actually have degeneration of the joint cartilage between these two bones. It's definitely the most common form of arthritis in adults. And it used to be known as wear and tear, but the paradigm has shifted a little bit, and we'll talk about that. So incidence and prevalence of osteoarthritis is very difficult when it comes down to finding the numbers, because there's a lot of people walking around with osteoarthritis in their joints, but we don't know that they have it because they don't have the symptoms yet. So it's really hard to give exact numbers. So take that as a grain of salt, because generally what we're seeing in terms of numerics are people who have symptomatic osteoarthritis. The clinical variability is super wide. So some people can have it in one joint, others can have it in multiple joints. Again, like we talk about, some people can have symptoms, others it's incidentally found when they're getting an x-ray or an imaging study for some other disease process. Some have joint pain, and then some can even have functional limitations. In terms of the cost of arthritis, in terms of how much it adds to the economy, we have almost a $10 billion effect in terms of absenteeism, whether that's happening at the school education level or even at the professional level. Total medical costs are about $136 billion, and the average direct cost per person per year is almost $11,000. So the whole economic burden altogether is nearly $65 billion in terms of medical expenditures. So it's a lot of money. People are very interested to see, how can we treat this? How can we slow it down? What can be done? In addition, people with osteoarthritis often have other comorbid conditions, and that can lower their levels of physical activity and then ultimately worsen their osteoarthritis. So what are some of these risk factors? So older age, as we get older, we start to maybe develop osteoarthritis in hands, hips, and knees. And typically we start to see this after the age of 50. Females tend to have osteoarthritis more frequently than males. The exact reason for this is still unclear. There's a thought process. There might be some hormonal background, but honestly, they haven't been able to really determine that. If you have some underlying autoimmune or inflammatory condition already, some mechanical problem like rheumatoid arthritis or gout, you might be more prone to developing osteoarthritis. If you have some genetic predisposition, for example, your grandparents or great-grandparents had it, it ran in your family, it's more likely to be there for you as well. So these are things that ultimately we can't modify. We can't modify our age or gender or our genetics. There are some modifiable risk factors, however. So the number one is probably obesity. So what we found is that when someone's BMI is greater than 30, that's the body mass index. It's a calculation based on one's height and weight. Almost 20% of patients are more likely to have osteoarthritis than not if their BMI is lower. So that's a pretty significant. We found that certain occupations, so for example, those that serve in the military, any profession that has some heavy physical workload, any job that has repetitive motions like bending, stooping, lifting, that can also cause some cumulative damage over time and increase the risk of osteoarthritis. And then finally, if you've had some previous joint trauma, so if you've had a meniscus tear or an ACL or MCL, these are some of the ligaments in the knees that have torn or had it damaged, or have had a previous bone fracture, that can also increase your risk for osteoarthritis. So just to keep these in mind, some things you can't change, some you could have some control on. So what are some of the signs and symptoms? What are things that you might notice that are happening to your body? So when patients come in and talk to their doctors, typically these are some of the things that they mention. Usually the joint pain happens in a way that it increases in severity with use and activity. So for example, patients will often say, the more I walk, the more I climb stairs, the more I'm doing my gardening, for example, the pain increases. It tends to get better with rest. In terms of the nature of the pain, it can be very sharp at first. And then if there's a specific motion or activity, for example, that bending or that lifting, it can make it much, much worse. The pain can also be constant as the joint degeneration progresses. So as the day goes on, typically it tends to get worse. And then finally, in more severe cases, it can actually progress from sharp all the way to a very dull, aching pain. Patients often say that, doctor, I feel really stiff. But what's interesting is the timing. Usually the stiffness only lasts seconds to minutes. It's typically less than 1 hour. They often say that, the doc, I feel like there's some gel in my knees, or when I get up, I just feel kind of stuck. But once I start moving around, it gets a little bit better. Finally, there might be some limited range of motion, and this can happen actively. So for example, a doctor may ask you to stand up from a chair or go up a couple steps in their office or go back down, or passively when the doctor actually pushes you through some motions or manipulations. So you might not be able to move that joint as far as you actually should in a normal setting. Other things that you might notice over time, there might be some bony swelling. So for example, in the hand, on these joints, you can start to formulate these nodes, and that can basically be the remodeling of bone or cartilage that is happening at the level of the joint. There can also be joint deformity, which usually means advanced damage. So as you can see, quite a bit of swelling and deformity of the knee joint. And finally, when things get very severe, or there might be other mechanical problems, patients may say to us, "Doc, my knee feels really unstable, almost like it's going to give away." They might even say it's even buckled a few times. So that makes us think either the arthritis is very advanced or there might be more mechanical things going on. Pathophysiology, I know this slide is very, very busy, but the main thing I want to get to is that in the past, it used to be thought that this type of arthritis, osteoarthritis, basically happens with age. As we get older, you get some degeneration in the joint. But now the paradigm is shifting. Now there's some thought process that there's some molecular derangement that's happening at the level of the joint that's actually causing a lot of inflammation. These are all pro-inflammatory markers. And what's happening is that the cartilage breaks down, the bone ends up remodeling. We start to develop these osteophytes, which are these bone spurs that you see. And finally, there is some element of inflammation, which is a very different thought process that was happening from 10 years ago. Ultimately, the combination of all of this leads to the loss of a normal joint function. So how do doctors make the diagnosis? We spent some time talking about the history. So how will a patient present to themselves? In terms of physical exam, we saw a couple of the bony deformities and swelling you might have on the slide previous to this. Joint fluid analysis. So when you come into the doctor's office, you might, for example, have some swelling in your knee. The doctor may say, "I think either myself or I need to refer you to a specialist to actually get fluid removed from the joint." This fluid is then sent for analysis, and it can really help us with diagnosis, especially because if we're thinking about some other disease process other than osteoarthritis. Imaging is also very helpful. The three most common imaging modalities are X-rays, MRIs, and ultrasound. The first image you'll probably be sent for is the X-ray. It's the most common modality. However, it's the least sensitive for early disease. So if you do have some of the symptoms we discussed above, but your X-ray comes back normal, I know it's a little disheartening because the doctor may say to you, it doesn't look like arthritis yet, but just remember in the early stages, it can be very difficult to diagnose by X-ray. The next test is typically an MRI. However, they're very timely. They can be very costly. The insurance programs are not very excited to pay for this. They might even ask you to, for example, try something like physical therapy or some other treatment modality before sending you for this. The nice part is it can really help identify early osteoarthritis, but also let us know if there's a problem at the level of the cartilage, if there's a problem at the level of like a ligament or a meniscus, or if there's even a problem at the level of the bone marrow. And then over the last 10 years, we've been using more and more ultrasound, and ultrasound is really helpful because it can help us identify if there's issues at the level of as superficial as a bursa, which is a pocket of fluid outside the joint, but also look for inflammation deep in the joint if all of these other modalities are not helpful. So what are some of the findings we see on the X-ray? In terms of the first thing is that you'll see that the cartilage wears away. And eventually when that happens, the joint narrows. And when that does, you often hear the saying bone on bone. So this is an example of a metatarsal joint where exactly that happened. This is an X-ray of a knee, very similar to that. As the cartilage wears away, you can also have damage to the meniscus. You might get something called sclerosis of the bone. If you ever see that in your radiology report, those are those kind of white lines that you see at the level of the X-ray. And finally, there can be bone spurs. That's what osteophytes mean. That's kind of what these blue arrows are pointing at here. But ultimately, if there's one thing you take away from this slide, after all the damage, the joint spaces are just very, very narrowed. So what are some of those mimics? Why is imaging important? Why is getting fluid out of the joint important if there's any question about the diagnosis? It's because you could likely have something else. So for example, rheumatoid arthritis can cause something called synovitis, where you can get redness, swelling, and significant inflammation of the joint. You can also have something called psoriatic arthritis, and finally crystalline arthritis, which can be demonstrated as either gout or pseudo-gout, where crystals actually accumulate in the joints. So this is an example of likely a gouty knee arthritis. So typically if a patient like that were to come into a doctor's office, they'd really like to remove fluid to see what's going on. And this is an example of very advanced rheumatoid arthritis over time. So we'll talk about kind of the three most common areas where, for example, a rheumatologist will often see osteoarthritis. Let's start with the knee. The knee osteoarthritis is the most common single cause of lower limb disability in people over the age of 50. I mean, that's a pretty big deal. You can have it on one side or even both sides. The knee typically has 3 compartments, and I know this is big wordage, but you might see your x-ray report say that you have patellofemoral arthritis or medial tibiofemoral arthritis. I'll show you what that means in a moment. But those are the 2 most common places that arthritis likes to settle in the knee. Typically, again, what the patients will say is the pain is increased after you're sitting for a long period of time or going up and down stairs. So real quick, this is what a normal knee looks like. Again, we talked about some of those imaging findings that leads to the joint space narrowing. When you have medial arthritis here of the knee, it can actually give you a deformity that makes you actually have bow legs. And on the flip side, if you have arthritis on the outside part of the knee, it can give you a different deformity that makes you have knock knees. So often physicians can kind of take a look at your gait, they can see how you're standing and see where the arthritis is. But this is a good example of advanced arthritis leading to physically visible deformities. Hands. This is probably the second most common place that a rheumatologist will see arthritis. Typically for osteoarthritis, both hands are affected. The joints where you tend to see osteoarthritis the most often are the distal interphalangeal joints. These are the DIP joints, and these are the proximal interphalangeal joints. When I talk to patients about this, I typically say it's the joint right underneath the nail and then the middle joint. The third most common place is at the level of the thumb. So the nodes up here, and I had showed this in a previous slide, are called Heberden's nodes. The nodes in the middle are called Bouchard's nodes. And if, for example, I was sitting next to an individual on a train with these hands, as deformed as they do look, interestingly, many patients will say, "Doc, they don't really hurt. I have a hard time making a fist, for example, or I have to get a little bit creative with how I hold my coffee mug." But sometimes when the damage has progressed very severely, the pain part kind of goes away, especially as the inflammatory component of osteoarthritis calms down. Lastly, as we talked about the thumb, you can get squaring of this joint here. This is what they call the carpal metacarpal joint. So this is probably the third most common place that osteoarthritis likes to settle. There can be even a more severe form of osteoarthritis in the hands. It's called erosive osteoarthritis. It can be very deforming looking, making the joints sort of twist in one direction and another. Again, about 50% of these patients will come into our office and say, you know, my grandchildren kind of look at my hands a bit funny, or I'm having a hard time gripping the steering wheel, but I don't really have a lot of pain. Is there anything I can take to reverse this? Unfortunately, no. But I do reassure them that at least the worst of the damage is done. This is sort of how the x-ray looks. And what's interesting about this type of arthritis is it does erode into the bone underneath it. Once sort of the damage has happened, there's not really much that can be done afterward. But I do reassure patients that sometimes the pain part of this at least does go away. So we talked about the knee, we talked about the hand, and moving probably to the third most common place that we see osteoarthritis in our practice is in the hip. So pointing to this x-ray here, this is a normal hip joint. It's a ball and socket joint. And with osteoarthritis, you tend to see, again, a lot of joint space narrowing. Something very interesting about the hip is that when patients come to talk to us, they often will point here or up here or even into their buttock area with regards to their thought being that, hey, I think I have hip arthritis. What's interesting is if you really look at where the hip joint is located, it's really in the groin area right here. So what's very neat about hip arthritis is the most common symptom is typically groin pain or side pain that radiates further into the groin. So if that's something you're appreciating, you may not initially think about hip arthritis. Many patients will think, is there something in my abdomen? Is there something in my pelvis? I've had some patients even tell me, could it be a kidney stone? But one of the first things I do is I typically get a hip x-ray if a patient starts to complain about groin pain. So we spent some time talking about the three major areas where we see osteoarthritis. We talked about the symptoms, the clinical presentation, and how they look on images, also how we diagnose them, especially if we need to remove some fluid. So let's move on to therapy options. So again, like I talked about on the introduction slide, we'll talk about pharmaceutical options and non-pharmaceutical options. I'll be taking some time to talk about oral medications, topical medications, and injections. And then in terms of non-pharmaceutical options, talking about mind, body, and lifestyle. In 2019, the American College of Rheumatology came out with some guidelines. And this was very new for us. We didn't really have a big data set to really work on and see how each medication, how effective can it be, what we can recommend for our patients. So a lot of my colleagues were very excited to see this. We'll talk about each of the treatment mechanisms, and then we'll delve into some charts that show like how effective can this be? Is this something that's really promoted? So pharmaceutical therapies, probably the first line agents that your doctors will recommend are NSAIDs. NSAIDs stand for non-steroidal anti-inflammatory drugs. The two that you can purchase over the counter are ibuprofen and naproxen sodium. The trade name for those are Advil and Aleve. Otherwise, there's prescription ones as well. Some of you may have been prescribed meloxicam or diclofenac or Voltaren. There's also topical NSAID medications, so diclofenac sodium gel. This went generic, I think, about 1.5 to 2 years ago, so you can actually purchase this at CVS, Walgreens. I've even seen it at Bed Bath & Beyond. Definitely talk to your doctors to see if these medications are safe to use. If you have a history of heart disease, if you have high blood pressure, if you're on any blood thinners, you've ever had a stomach ulcer, or if you have kidney problems, these are medications that should really be used with caution. So definitely consult your doctor. Other pharmaceutical therapies that are used are injections, acetaminophen or Tylenol, tramadol, duloxetine or Cymbalta, which is a depression medicine that has really good benefits for arthritis and migraines and nerve pain, chondroitin, and then one other topical agent called capsaicin, which is often used for neuropathic pain for patients with diabetes. Opioid medications. Anytime you're driving up and down the freeway, you might start to see these large billboards really cautioning patients about opioids. Anytime you open the newspaper or the website, there's a large problem with the opioid epidemic going on. Although guidelines don't recommend opioid medications, the data shows that about 16% of patients receive them with knee osteoarthritis. That's a pretty significant amount. Some things to keep in mind, if it comes to the point of needing opioid medications, they're associated with worse baseline pain and typically a lower quality of life. If they are necessary, and sometimes they are, it's best to use them for a short period of time and at the lowest doses possible. It's typically recommended if the disease is very disabling. Side effects to watch out for if you are prescribed one of these medications is dependence. They can be sedating, so try not to drive or operate any heavy machinery. In high doses, they can cause breathing and heart problems. They can lead to constipation and nausea. So they can be necessary in certain cases, but definitely use these medications with caution. Injections. So we're going to be talking about 4 injection modalities coming forward. After medications and prevention, this is probably the 3rd most common topic that's discussed by me and my colleagues with our patients. So steroid injections, these can be given into a lot of joint areas, but most commonly the knee, the hip, the shoulder, and the hand. The theory behind steroid injections is pretty simple. Steroids reduce inflammation, so if there's some inflammation in that particular joint, hopefully the steroid would help. However, what the data has shown is that it's more beneficial if there's actually inflammation present in the joint. So depending on where you are at the timeline of your osteoarthritis, if you are already at the way end of extreme damage, burnt out, past the inflammation, the steroid injection may not be as helpful as it is with mild or moderate osteoarthritis, where you have higher levels of inflammation markers in the joint. Typically, it's more short-term relief, weeks to months. You can actually get these injections as often as every 3 months. Some patients can go as long as 6 months and get enough relief. Overall, they're safe, but if this is something that you're going to be using as a long-term management, definitely talk to your doctor about it, especially if you're someone who has diabetes and are having trouble controlling your blood sugars. In terms of side effects, the shot itself can cause some temporary pain, some redness and itching. Infections, although they're mentioned usually when you're describing the procedure to a patient, are typically very, very rare. So this is probably the first line injection that's offered to our patients. The second most common injection we're asked about are viscosupplementation. The actual substance that goes into the joint is called hyaluronic acid. So the concept behind this is that it provides lubrication and shock absorbency for the joint. So just to give you an idea, a normal adult knee has approximately 2.5 to 4 milligrams per milliliter of hyaluronic acid present. What researchers found is that in an osteoarthritic knee, this is down by anywhere from 33 to 50%. So the thought process is that if you could inject this into the joint, could you possibly lubricate it, give it a little bit, essentially gel or cushion, and hopefully buy it some more time until you might need something like surgery. It's typically only used for the knee. I'll show you a graph chart a little bit later on where there's some mention of it used in the hand. It's not really used in any other joint area. There's a couple of preparations, essentially a few brands. Synvisc is one of them, Gel One is another. They essentially vary by molecular weight and dosing and preparation method. Patients sometimes ask me, this year my orthopedic surgeon has Synvisc One, next year he has a different brand. Is that a big difference? Unfortunately, there's no data to recommend one brand over another. However, two things to kind of keep in mind. This does typically give more sustained benefit than a steroid injection. So typically patients will say anywhere from 3 months to even 1 year from a gel injection if you're the right candidate for it. However, sort of similar to steroid injection, it's less helpful when the arthritis is very, very severe. The third type of injection that we get asked about is called platelet-rich plasma. Most of the academic centers, university centers, these next two injections we're going to talk about, they don't partake in them. In terms of describing what this is, a blood derivative is taken, and essentially a high level of platelets is concentrated together and then collected like this and prepared like this. The idea being that this platelet-rich plasma would promote tissue healing. There's possibly a slightly more benefit than this compared to the gel injection, but again, less helpful with severe arthritis. And here I'm going to point out to you, it's not FDA approved. The fourth type of injection we get asked about is stem cell injections. And the idea being that you take cells from your body, typically harvest them from the bone marrow or from some fatty tissue, prepare the cells, and then inject them right back into your knee or other joint. The idea being that hopefully these cells would then differentiate into osteoblasts and chondrocytes and promote a more balanced and less inflammatory joint environment. There's some thought there's some anti-inflammatory properties, but again, not FDA approved. So again, getting into these two injections, typically what patients will do is that they will bring me advertisements that they see in the newspaper from their local suburb or magazines from the city, for example, and it'll be a lot of private practitioners who are partaking in either the PRP injection or the stem cell injection. And I often tell the patients to please go ahead and talk to the doctors, because although we don't participate or partake in them, there are some patients who have benefited from them, but to definitely know the risk factors. So keep in mind, this is a chart or table that goes back to that first guidelines from the Rheumatology Society. Red is essentially something that they do not recommend. And so just pointing out that the PRP injections and stem cell injections are sort of not recommended for any type of arthritis. The next most common question we get asked is, Dr. Haseeb, I see commercials on television for things like Humira or Xeljanz. They say that they can help my arthritis, in fact, reduce the symptoms. Could I use it? So a lot of research has been done to see if anti-rheumatic drugs, especially biologic medications, as well as these anti-rheumatic drugs like methotrexate and hydroxychloroquine, could they actually help osteoarthritis patients, especially now that there's been a paradigm shift that there's more inflammation in these joints. As you can see here, there've been data done for hand, knee, and hip, and all the way down the board, it looks like none of these agents are helpful. So although they've been researched, it doesn't look like the medications that work for inflammatory or autoimmune arthritis are helpful for osteoarthritis. So we talked about pharmaceutical mechanisms or treatment options. Why don't we move on to non-pharmaceutical approaches? So this would be mind and body. The one thing I want you guys to take away from this chart here, patients often ask me about bracing. So for the knee and hand, and again, I would definitely confer with your sports medicine doctors or your orthopedic surgeons. Depending on the type of arthritis you have, a knee brace or a hand or thumb brace can be helpful. So that is something that you could often pick up from the drugstore. We've seen them on sale at like Walgreens or CVS, or you can even get them from a durable medical supply store as well. So depending on the type and severity of arthritis, bracing could be helpful. So does the type of shoe matter? So a lot of the brands now have been coming out with these new sneakers that often resemble wearing socks. We see a lot of patients coming in with these new tennis shoes, which are not really tennis shoes. And they often will ask, Doc, I've purchased these new sneakers. What do you think? Does the type of shoe matter? So flat flexible versus a stable supportive shoe is the main question at hand. This would be an example of a flexible shoe. So you can see there's quite a bit of bend that happens at the level of the toe joint. The way you could kind of test it out is if you could actually squeeze the sneaker in half, that's probably a flexible shoe versus a more supportive shoe with a very, very stable sole. So there was a study done by Patterson's group just this year where they did a randomized control trial. That's a really good experiment where they took 164 patients and they put half into a flat flexible shoe like this, half into a stable supportive shoe like this. And what they found were that the flat flexible shoes, these new popular sneakers that are supposed to be so amazing to wear, they were not better than the stable supportive shoes. And even more interesting, those that wore these stable supportive shoes actually had less pain and improved knee pain upon walking. So that's kind of a big deal. So if knee pain is something you deal with, definitely look into your closets, see if a shoe change needs to be made. Moving on to other non-pharmaceutical therapies, so into lifestyle. Exercise, super important. Swimming, biking, brisk walking, dancing are all very good. Resistance training, make sure you include that into your exercise. They really help prevent breakdown in other areas by the joint and help strengthen the muscles around the joint, which is very important. Ultimately, it also improves flexibility. Tai Chi and yoga have also been found to be very helpful. Maintaining an ideal weight. So the one question we get asked, is there anything we can do to reverse our osteoarthritis? This is the only thing that can be done. So if you are overweight, losing weight can actually slow the symptoms of osteoarthritis. By decreasing your weight by even 5 pounds, you can reduce the pressure on your low back and knees by anywhere from 25 to 40%. So that's a very big deal, and hence improve overall function. So that's definitely something we all advocate for. Exercise. So patients will often ask, how should I go about doing that? Should I get on an elliptical machine? Should I get on a treadmill? Is one necessarily more detrimental to my hip and knee and low back? So what's interesting about ellipticals and treadmills is, in fact, when you look into the kinesiology of the exercise, they exert the same force. However, when they looked at and explored the gliding mechanism, although the actual force is the same, there's in fact less stress on the knees and hips and back compared to jogging or running on a treadmill. So I would agree, if you have moderate to severe osteoarthritis of the knee, hip, or low back, it's probably easier on your joints to use an elliptical. It's very important that posture is that you look into your posture very carefully on an elliptical. And what that means is shoulders back, head up, core in line with your pelvis is very, very important. The reason is that gliding mechanism, it doesn't exactly or precisely match a walking mechanism. So we don't want to worsen anything. So if your posture isn't right, if you're leaning on the arm part of the elliptical, you could be causing more damage long-term. So definitely watch out for your posture. Patients also ask about the stationary bike, especially as the Peloton has become much more popular of an exercise equipment, and stationary bikes have been shown to improve pain and function when it comes to osteoarthritis in the knee, back, and low hips. So just a key point, low impact exercise, very important. Important to do cardiovascular as well as resistance training. And if you do have moderate to severe osteoarthritis in those 3 areas, probably using an elliptical with good posture is very important. Moving on to nutrition. Is there something I can eat or drink to slow things down? Unfortunately, for nutrition, data is limited. There's a lot of anti-inflammatory diets and lifestyle out there. And the main thing to know is that there's no one diet that fits everyone. You almost have to find what works for you. When patients ask me and my colleagues about what the best diet to follow is, we often will recommend the Mediterranean diet. And again, you can modify this to make it work for your food, your culture, your family. The essence of the diet is very simple. And many people actually, because of the pandemic, have moved into eating like this anyway, with restaurants and various things closing. So whole diet with unprocessed foods, typically farm to table, so you know exactly what's going into your food. Promotion of monounsaturated fats, so using olive oil as well as fish and plant sources for omega-3 fatty acids. It's much more fruits, vegetables, and fiber, less meat, for example, less sugars, and try to avoid low or simple carbs that are digested quickly. So try to avoid low glycemic index foods. So it's mainly preparing what you know at home and try to avoid eating out as much as possible. Other things, and these are really common sense. If you're smoking, please stop. Limiting alcohol intake, a lot of unnecessary calories, as well as maybe just general detriment to health. Reducing stress, and of course, good sleep hygiene and sleep quality. Another thing that patients often commonly say to me is, "Doctor, why do my joints hurt a lot more at night with this osteoarthritis?" Unfortunately, it's really a vicious cycle. With osteoarthritis, especially if you get awakened by pain, you end up having decreased delta sleep, which is where you have restorative sleep. When that happens, your pain center, your receptors for pain become hyperacute. They become even more aware of the pain. So it ends up being this vicious cycle. Main thing is, again, behavioral measures. So making sure that you're going to sleep at a good time, not having any distractors in your bedroom. For example, like TV and whatnot. Making sure the environment is very calm, and also timing of meds. So if you are actually unable to fall asleep because of the pain, or you're finding yourself waking up an hour or two into your sleep because of the pain, maybe taking an anti-inflammatory NSAID medication or acetaminophen or using any of those topical agents an hour, half an hour before you go to sleep is very important. So definitely talk to your doctor about the timing of meds if nighttime symptoms and sleep issues are a big problem. Other modalities, a little bit about mind and body. These are relatively safe and useful adjunct therapies. Biofeedback, in fact, just out of curiosity, I just hit biofeedback machines on Amazon this afternoon. A few came out. You can, basically these machines help your mind and muscle train how they will react to certain movements. There's also mindfulness techniques. So some of our patients will journal, for example, or use sensory imagery. I have, in fact, had a patient who once used hypnosis, and that seemed to help. Just anything that you can to really get your mind off the severity of the pain, or at least train your mind to decrease the pain that you're feeling at the time when the symptoms are at their worst. Acupuncture, this is a very common thing we're asked about. It's been used in China for approximately 2,500 years. And we know that there's some general therapeutic value for a lot of chronic conditions. You know, some patients with, for example, inflammatory bowel disease and strokes and high blood pressure often will turn to acupuncture. There were two studies, one done in 2006 and another one in 2007, who looked at the benefits of acupuncture with osteoarthritis. And what they found is that there was a statistical difference in improvement in people with knee osteoarthritis compared to those who sort of had a placebo or a sham acupuncture procedure done. So what patients experienced was improvement of pain and range of motion. A couple of just things to keep in mind with acupuncture. It's best to talk to maybe your friends, family, colleagues, or doctors to see if they're aware of a clinician. It's best if the clinician is certified or boarded, and definitely find out where they did their training. And once you start acupuncture, what the data has also shown is that you probably have to continue it long term. Once acupuncture is stopped, they found that the benefits of what you experienced while you were doing it kind of wear away. So it's almost as if this is something that really helps you, you have to continue it long term. Other options include massage and chiropractic manipulation. And again, those are things that you can talk to your physician and insurance company about to see if they could be even covered for your osteoarthritis. Moving on to some dietary supplements. Again, a very hot topic now. These are just a list of some of them. The two big brands, often patients will actually bring in their bottles to our office. One is OsteoBiflex, the other is Move Free. And if you actually turn around and look at the ingredients, it's typically a combination of anywhere from 2 to 4 of these substances. And to focus first on the most famous of these two, glucosamine, chondroitin, overall, these are pretty safe. However, they've really caused a lot of controversy in the last 15 years or so, where patients used to take this very, very regularly. However, efficacy data is very mixed. So in terms of doses, because patients will often ask me about that, for glucosamine, what clinicians will often advise is taking 1,500 milligrams of this divided into 3 doses. The idea is that glucosamine stimulates these cartilage forming cells. So hopefully you might have healthier cartilage is the thought process. Patients ask me, well, it has the word glucose in it. Does it really affect my glucose level? The good news is it doesn't. It is derived from the shell of a shellfish. So although you may have a shellfish allergy, because it comes from the actual shell and not the meat portion, typically patients tolerate this well. So again, overall safe and something to consider. The second supplement is chondroitin, typically recommending 1,000 to 1,200 milligrams daily. And again, this can be taken once or in divided doses. Chondroitin is found in the cartilage of most mammals, and it helps decrease cartilage breakdown when taken by mouth or orally. Something to keep in mind, typically this is taken from cow cartilage. So I have had patients who, for example, are vegetarians, strict vegetarians, and so I tell them typically avoid chondroitin because you can never really know where it comes from. And there's been some case reports that if you have really bad asthma, it could potentially make this worse. So 3 points about this. Very common substances. They're in a lot of the these bone supplement medications you'll buy over the counter. Overall, very safe. Keep in mind, data is mixed, so it's not going to really slow things down, but it might make you feel better. So I often tell patients, try it for six to 9 months. If you notice a difference, then it might be worth continuing. The two sort of less known substance, one is called SAMe. And again, a little bit about the dosing here. The mechanism of how this helps is really unknown, but somehow it stimulates production of cartilage and reduces pain and inflammation. Again, overall, this supplement is overall safe. However, if you're on some antidepressant medication, just use it with caution, and it can cause some stomach upset. The fourth supplement is called MSM. And again, it's been shown to prevent joint degeneration. It does contain sulfur. So if you have a sulfur allergy, be careful. And again, overall, it's safe. So just going back, these are the 4 most common, and most of the supplements will have some combination of this in it. Worth trying for a few months, and if it helps, continue. But there's no data saying that this is actually going to reverse or slow down your osteoarthritis. Turmeric. So there are multiple herbal supplements that I listed, but this is probably the one we get asked about the most. The active ingredient being curcumin, and dosing wise, anywhere from 1.5 to 3 grams daily, divided into several doses. It can even be prepared in a tea. So 1 heaping teaspoon has about 4 grams. So that's a lot. Even if, for example, you're preparing Indian food, you don't use that much turmeric in a dish, for example. Benefits of turmeric: decrease of inflammation. It can actually lower your bad cholesterol, or LDL, and raise your good cholesterol. There's some antiplatelet effects and antioxidant effects. So if you're on a blood thinner, just make sure you consult your doctor before taking this as a supplement. However, in very high doses, it can cause a lot of burping and stomach upset. So patients have mentioned that taking this as a supplement has reduced pain. Again, I often say, try it. It's typically very safe. And if it helps, something to continue long-term. Otherwise, you can discontinue it. So what questions should you ask your doctor? Which medications are best to treat my pain? Are there any side effects? If so, what are they? Especially if you're on a lot of other medications, we want to make sure there's no interactions. What do I do if my medicine stopped working? Will shots help my joints? What non-pharmaceutical options you recommend? And then when or if will I need surgery? So in terms of when you should see a surgeon, everything we talked about is essentially a conservative measure. So if all of those pharmaceutical and non-pharmaceutical measures stop working, definitely look into seeing a surgeon. If you start having constant joint pain and stiffness, so all your waking hours are spent with a great deal of pain. And finally, if it's limiting activities of daily living. That's it.
So Dr. Gafur Hasib, that was an excellent presentation. Thank you very much for that. It was pretty comprehensive. You talked to us about what osteoarthritis is, what can we do to help it, how can we prevent it, what can we treat, the supplements. It was excellent. We have a few questions, so let's go for it. First question we have is, are habitual sitting postures not recommended?
So I'm glad someone brought that up. If you looked at my first slide, it actually mentions that cross-legged sitting or sitting in a particular way for long periods of time could increase. It's one of the risk factors. I think it's on this slide right here. Habitual floor activities, kneeling, side bending, squatting, for example. Ultimately, it is a risk factor, but if your job entails it, for example, I have patients who are daycare teachers. They spend a lot of their times moving up and down, or people who work in factories where there's just assembly line repetition work. We can do our best to modify the job, take multiple breaks, but yes, unfortunately, it is a risk factor.
Thank you. So the next question is, what are ways to naturally increase the lubrication between the joints?
So remember I spoke about those dietary supplements, the 4 of them, the SAMe, MSM, glucosamine, chondroitin. The concept is those supplements can possibly increase your lubrication. Naturally, I would assume that maybe some of the herbal supplements like turmeric, for example, or ginger, garlic root, there's some thought about it, but no data has shown that it actually increases it substantial enough to slow down arthritis. Now, will it make patients feel better? It's possible. So I always recommend patients try it. But there's no data to show that there's one substance better than another.
Thank you. There are some excellent questions here. Next question, can you elaborate about biofeedback machines, please?
Sure. So you can actually, typically the type of physician you'd want to talk to this about is either a pain physician or a physical medicine and rehab physician. These can be purchased over the counter. Again, I don't know how good they are because I've never prescribed them personally in my practice, but typically the idea is that they work with your muscle groups and your mind and really help figure out when is at what points the pain levels are high and how can they go about to reduce that signal down the road to your brain. So how can they work on that triangle together? Again, I personally don't prescribe them, so I don't know about a lot of them in detail, but if that was something you'd want to explore, I think probably a pain physician or a physiatrist would be the physician to ask that about.
Okay. So the next question is, what do you suggest for severe osteoporosis? We are switching gears to osteoporosis. What do you suggest for severe osteoporosis besides bisphosphonates and similar medicines?
So interesting question. So osteoporosis, very different than osteoarthritis. Osteoporosis actually has to do with bone density. And so the way that gets diagnosed is with a bone density scan. Some thought process is that osteoporosis, could it be protective or increase your risk for osteoarthritis? We still don't know. The first line treatment for it is bisphosphonates, as the patient mentioned, as the attendee mentioned. Those can be given orally or IV, for example. There are reasons why a doctor may recommend that you use one or the other. And you can often talk to your rheumatologist, endocrinologist, OB-GYN, or primary care physician about it. However, if those types of medications are not good, we do have hormone therapies as well as some of these new anabolic agents that help build bone. So potentially maybe the attendee is thinking about something like Prolia. Again, there's a few new medicines out there. They have their own risk factors, and depending on the severity of your osteoporosis and other medical conditions, they might recommend one over the other.
All right, there's this interesting question. Any relationship between sleep apnea and osteoarthritis?
That's very interesting. Not that I've found, but patients do mention that poor sleep kind of makes their pain increased for sure. So I think if anything, if you have any concern that you have undiagnosed sleep apnea, for example, you are snoring a great deal at night, your spouse or significant other notices that you stop breathing, I would very much recommend that you talk to your primary doctor about getting a sleep study as soon as possible. Because if anything, we know that improved sleep helps osteoarthritis symptoms. So if there is any undiagnosed sleep apnea, if it's treated, it's probably the best.
And there's a question on aspirin, the effectiveness of aspirin for osteoarthritis.
Has not been found to be effective. It's not a great modality for reducing inflammation, and with its antiplatelet effects, also not a good long-term treatment for osteoarthritis.
And I think that is what we have for questions, but we have a few thank yous from the audience members for the presentation. I'll read out a few. Great webinar. Thank you so much for your advice on exercise, weight control, nutrition. Love the farm to table food recommendations. Sincere thanks once again. Excellent program for novices. And thank you, Asha. Appreciate your attendance. Okay. So that is our questions. So thank you very much. It wasn't like I have to echo the audience. It was an excellent presentation, and we learned a lot. We learned a lot about osteoarthritis, what can we do to prevent it, how can we help ourselves, what questions to ask our doctors. Pretty comprehensive. Thank you.
Thank you. I appreciate it.
Of course. Audience, thank you for your participation and for your excellent questions, as always. Thank you for tuning in. And remember that this is informational. So if you have any specific questions regarding your health and regarding questions you have about you, please discuss that with your doctors. We want to thank the Schaumburg Public Library for hosting this webinar and for all of the audience participation. So thank you all for attending and happy holidays. Hope everybody has a great holiday season.
Thank you.
Thanks.